Good morning, everyone. We're going to start the session about patient selection for focal therapy. I would like to invite Dr. Villers, Dr. Arnauld Villers. He's the chairman of the Department of Urology at Lille University at France. He's going to talk about the scenario where focal therapy for grade group 1 is reasonable.
Okay, dear colleagues, dear friends. So this is a question which have been discussed during the last 2 days. And so behind this question of scenario, I mean, grade group 1 versus tumor volume should be there. High volumes of GG1 at biopsy. We all know, and we saw that in the previous presentation, that there's a risk of underestimation of some GG2. And so also low volume GG2, we should recall that, often behaves clinically similarly to GG1. So I will recall 2 results of consensus. In this one held by Lebaschi, the expert panel found no consensus that GG1 tumors could be defined as index lesions to be treated. So no consensus. But they reached agreement that in all biopsy-confirmed MRI visible low-volume lesions with clinically significant cancer as GG2, they should be used as a target. And in this November international consensus held by Caroline, the report showed that GG grade group and MRI findings were the most important criteria for selection of active surveillance, and then PSA-AD and PSA being the next most important ones. So I'm turning around focal therapy, and active surveillance is, as we just saw on the left side. So there was much discussion on the use of other parameters like cancer core length, tumor visibility, and tumor volume and MRI. So two references. This study from the UCL UK series from Travinides, who showed this event-free survival treatment of any treatment on active surveillance series. And this was displayed with these 4 subgroups. The brown one, the upper one is only 3-3, GG1, sorry, and no cancer visible. And the green one is GG2 with cancer visible. So you see that they are very close to each other, I mean, for the 3 first. And, but there is a significant difference between all these curves. And so the conclusion was that in MRI visible tumor disease, I mean, with certain amount of volume, and or a secondary Gleason grade 4 at baseline, associated with a greater likelihood of moving to active treatment. And then active treatment for us would be for many patients focal therapy. So tumor volume and MRI visibility matters. And this is a recent publication also from the Movember group, who showed that these 2 curves, visible and non-visible tumor, have different, significantly different meaning for active treatment in active surveillance patients. So my first conclusion would be to say there are no reasonable scenarios where focal therapy, I would say, or active surveillance for cases selected only on GG1 parameter. And all GG1 cases cannot be defined as non-significant cancers. MRI visibility and tumor volume should be associated to this definition. This is not the case in many articles, but this is my conclusion. So we need RCTs to explore that. And actually, one RCT was started a few years ago in France by Sébastien Crouzet. It's a phase 3 RCT, 10 French centers, 146 patients included, and the inclusion period closed this year in March. So the design was focal HIFU versus active surveillance. In these patients with GG1 at biopsy. Then they added for inclusion criteria that the MRI volume should be there because it should fit with focal therapy also, so more than 0.5 cc or largest diameter more than 10 millimeter, MCCL maximum cancer core length 3 millimeters, and or 3 positive biopsy either at systematic or targeted. PSA should be less than 15. I mean, these criteria were too much, both indication, active surveillance, or focal therapy. So the main objective was the reduction of whole gland treatment rate at 48 months in the HIFU arm, and so we should expect these results within 2 years. Thank you.
We have time for one question. Thank you, Dr. Villers.
Thank you.
So moving on with the next speaker, Dr. Rothberg. He's from Duke University. He's going to speak about should non-imageable cancer be treated?
All right, hi, good morning. I'm Mike Rothberg from Duke University. I'd like to thank the Focal Therapy Society and organizers of the annual meeting for the opportunity to discuss, or at least start a discussion on whether non-imageable cancers should be treated. And I have no disclosures. So with respect to imageable and non-imageable disease, what do we know about the ability of multiparametric MRI to detect clinically significant prostate cancer? Well, as we've seen presented many times at this conference, it's very good, but it's not perfect. High-level data from trials like PROMISE, Precision, and MRI First, and many others indicate that a negative multiparametric MRI will miss clinically significant disease about 15% of the time. And so what could possibly account for this? Well, lesions that are lower grade, potentially less aggressive or very small, might not be captured on multiparametric MRI. And lesions with mucinous features, although very rare, have been associated with poor MR visibility. And additionally, there are well-documented variances in inter-reader interpretation of multiparametric MRI, and this can affect whether or not lesions are defined as visible, equivocal, or invisible, and ultimately if and how they're biopsied. And so our field has also learned that multiparametric MRI underestimates histological tumor volume, and this is work from Dr. Tanasia's group at NYU, and they compared prostate tumor boundaries on multiparametric MRI to co-registered radical prostatectomy histological specimens. And again, they found that MRI underestimates histological tumor boundaries, and this underestimation was worse for lesions with higher imaging suspicion score and a higher Gleason score. Work like this has guided focal therapy best practices with respect to treatment margin to ensure oncologic control. Work from Michael Adut and others who came before me at the urologic oncology branch looked at patients who underwent multiparametric ultrasound, MRI and ultrasound fusion targeted and systematic prostate biopsy. And when the cancer detection rates and pathological grade on targeted and systematic biopsy were compared to histological grade on final prostatectomy pathology, if only MRI targeted biopsies had been performed, 8.8% of clinically significant cancers, essentially those that are MR is invisible and captured only on systematic biopsy, would have been misclassified. And so at this point in the discussion, what can we say? MRI is not perfect, and inevitably clinically significant disease will be identified in some patients without association with an MR visible lesion. So this non-imageable, clinically significant, potentially prostate cancer exists, and despite all the advancements in imaging we've seen presented at this meeting, not all of it will be visible. And so if clinically significant cancer cannot be seen on imaging, how does one know what to treat? What's the ablation plan? How do we define treatment margins? What can be said about the biological aggressiveness of cancers that are visible or not visible? And does this qualify or disqualify patients from focal therapy? What else do we know about this subset of prostate cancer? And so this image has been showed many, many times at this conference. This is work from Wayne Brisbane in collaboration between UCLA and Cornell. And they proposed and studied the concept of the umbra and the penumbra surrounding an MR visible lesion. And overall, 90% of clinically significant prostate cancer identified on biopsy was located within 10 millimeters from the nearest MR visible lesion. And additionally, the width of the penumbra, which enclosed 90% of clinically significant disease, was primarily related to MRI grade of the lesion. And only 6.1% of patients with clinically significant prostate cancer had the cancer located greater than 10 millimeters away from the MRI region of interest surface. And so this suggests that while all clinically significant disease might not be located within the strict boundaries of an imageable lesion, the vast majority is located within these concentric regions surrounding the region of interest. And the rates of clinically significant cancers located far away from MR visible lesions is relatively low. Moreover, another study from Dr. Taneja's group sought to determine the rates of missed cancers when the precision trial biopsy strategy was applied to a cohort of over 600 men. And the relevant finding to highlight from this study is that missed clinically significant disease is highly likely to be located ipsilateral to the MRI target. And so in theory, knowing the results of these two studies, would treating MR visible lesions with an appropriate treatment margin and not treating non-imageable cancers yield acceptable oncologic outcomes? So what evidence do we have regarding the natural history of biological aggressiveness of MR visible versus invisible prostate cancers? And this is work out of UCL that's also been presented many times at this meeting. And in the center column, it illustrates the bottom line, which is essentially that MR visible disease at baseline was associated with shorter event-free survival for patients with both grade group 1 and grade group 2 disease. And this is an excellent paper of MSK that I've seen presented several times at the meeting. It's worth reviewing again. 1,500 patients who underwent radical prostatectomy with preoperative multiparametric MRI. And following treatment, those with MR visible disease were significantly more likely to have biochemical recurrence and significantly more likely to develop metastatic disease compared to those with equivocal or occult lesions. And as Dr. Katz alluded to yesterday in his talk, there are many recently published basic sciences and translational studies that appear to indicate that biological aggressiveness drives lesion visibility. And so in this study, you had MR visible and invisible lesions that underwent RNA sequencing. Interestingly, their analysis indicates that it was not Gleason score and tumor size that determined MR lesion visibility, but the presence of these 4 specific genes shown here predict lesion visibility and biological aggressiveness. So very quickly, some conclusions. MRI is very good, but it's not perfect. We discussed the penumbra of clinically significant disease around MR visible regions of interest and ipsilateral nature of the majority of clinically significant cancers. Compared to MR visible lesions, invisible lesions appear to have a more favorable clinical course, and biological aggressiveness appears to drive lesion visibility. Thank you.
A quick question. If we decide to treat this patient, do we have to change our biopsy strategy? For example, with template every 5 millimeter biopsy? What are your thoughts about that?
In terms of like a diagnostic systematic biopsy, or
to try to guide the energy, to try to target the area that we're going to treat, we need some guidance.
Sure.
If it's not coming from the MRI, we should change our biopsy strategy to try to do the treatment?
So just to understand, I think that the modalities that we use currently, where MR targeted biopsy, take multiple samples of a target lesion, perhaps saturate the area around an MR visible lesion, I think that strategies like that could be appropriate. I think it's dependent. I mean, current standards here, at least, are to do adequate systematic biopsy as well. And I think depending on provider preference or their comfort with it, they can adjust their biopsy strategy appropriately.
Perfect. Thank you.
Okay, understood. So in the setting of a negative,
how would you prepare to treat someone with a negative MRI?
Yeah, no, I agree. So in that setting with high clinical suspicion, I think that your biopsy has to adapt to that based on other factors as well. Thanks.
Question over here.
Please.
Okay. From a practical standpoint, one thing that happens often is there's an MRI visible index lesion that you're in there treating, but because of the systematic biopsy, there's some MRI invisible other foci that are clinically significant. Do you advocate then just using landmarks to go? You're there treating the MRI visible lesion under MR guidance, so why not go use landmarks and do a treatment for the MR invisible disease?
It becomes really difficult, and I think that's because when you do have these MR invisible lesions, it's tough to say what their extent is because we no longer have that visual guidance, and so the question becomes, how far do we extend to that? How far do we do that sort of treatment? And so I think depending on what the results of the biopsy are, the concentration of those clinically significant lesions, that then asks the question of, is this an appropriate candidate for focal therapy?
Thank you. Okay, so we'll move on to the next presentation. We have Dr. Minhaj Siddiqui coming to us from Maryland, University of Maryland, going to talk on opportunities for molecular markers in focal therapy, which is a good topic, when and how.
Great, thank you so much. It's a pleasure to be here. Thank you for the organizers for the invitation. So I don't have any relevant disclosures for this talk. Role of biomarkers for focal therapy. So there's a couple of key things I want to run through. It's a short time period. It's a big topic. Is there a role for biomarkers in the selection of focal therapy? I think if you treat prostate cancer, you are familiar with biomarkers. They are not designed for this purpose, yet they are designed for very complementary purposes, and so intuitively it makes sense that there may be a role. But the optimized utilization of those biomarkers for this purpose is still unclear, right? And so that is where we start. My hope is not to give you any answers, but perhaps to give you a framework for your own practices on how to organize this information. I think the starting point is to think of biomarkers in two big categories, the localization biomarkers and the characterization biomarkers. And I think that if you just start with that, it'll at least give a little bit of clarity. And I think that, certainly MRI, if you call it a biomarker, depending on how expansive your definition of biomarker is a great localization tool for your prostate cancer, right? And so, but we know that there are some shortcomings to MRI, and so you can miss clinically significant disease, and this is where these other biomarkers, whether they're serum-based, urine-based, or tissue-based, may be helpful to give you further confidence or actually help you raise questions on whether you're truly characterizing the disease accurately. And that will help you make your decisions better. Then there is the kind of opposite side, the characterization, where above and beyond the Gleason score and other kind of pathologic outcomes that you have from the biopsy and imaging ahead of time, you can have insights into the potential future biologic ability of the cancer. And so that would be like your Polaris oncotype decipher testing and whatnot. So I'm going to run through these again very quickly. And so prostate health index is a blood test. It's a PSA derivative with pre-PSA. It's FDA approved for men 50 and over with a PSA between 4 and 10 and negative DRE to identify clinically significant cancer. And it has certain cutoffs and ultimately has a C index of about 0.82. Okay, so I think I mentioned this because you'll see a theme in just a few seconds on the kind of predictive capabilities of these tests, and spoiler alert, they're all the same, and so essentially, I think that it gives you a little bit of a sense that you may be missing clinically significant disease. This gets tricky, right? Because clinically significant disease often for these studies and for these biomarkers is defined as any Gleason 7, which includes grade group 2 or grade group 3. Grade group 2 may well be the disease you're treating in the first place with your focal therapy, and so it simply may be just kind of reinforcing that you have disease, but at least it helps you identify that there is, if the test is kind of way beyond what you would have expected. It helps you kind of look back and make sure you're not missing something. Optical 4K score, same thing. It has a C index of a 0.82. It's also a PSA marker. And then you have like the Select MDX urine-based test for, again, grade group. This is actually for grade group greater than 2. So this is helpful, and it has an AUC of a 0.76. And the ExoDX test. ExoDX test is good for clinically significant disease and has high sensitivity, low specificity, right? And so the way you think of that is like you see that curve, and if you're below, blue is non-aggressive cancer. The red and yellows are more aggressive, and so if you're below that cutoff line, it's pretty much all blue. If your test is low, you can feel pretty good that there's a low chance that there is more aggressive cancer. If you're above that line, there's a good mix of blue and non-blue, and so it's not a very definitive. That's where the low specificity comes into play. The Confirm MDX test, I know there's been I haven't seen anything published on this, but I know people have played around with the idea. To me, this is one of the more promising tests for focal therapy because it lets you have a halo investigation around the biopsies, right? And so if you do a 12 core and you were to get halos of investigation around each biopsy on whether there was cancer nearby, right? This could give you that test, and so I've always felt that this is promising, but I think it hasn't quite played out yet. But I put it here that this is a test that can help identify cancer potentially near a biopsy that you had. Part of the reason its indications are for prior negative biopsies, so it's tricky getting the reimbursement right and everything like that. That's really the issue. And then lastly, we have the characterization test. We have Polaris. With an endpoint of prostate cancer-specific mortality. We have the Oncotype with the endpoint of favorable pathology at time of prostatectomy. And we have the Decipher, which has the numerous outcomes, including prostate cancer-specific mortality, metastatic disease, and also upgrading at time of prostatectomy. All of these have pretty good performance in terms of insights into, again, the biologic potential of the disease. It's worth noting the FTS study that was done, the consensus panel that was done, and on biomarkers, and it showed 3 main things. Evidence for the role of biomarkers is low. Molecular biomarkers should not be used as routine. MRI is more accessible than biomarkers in context of focal therapy. So again, the society kind of confirming what we already knew. So just to summarize, the role of biomarkers in patient selection for focal therapy is not defined. Studies are needed to understand this better, and in select scenarios, biomarkers may really hold a significant benefit, and I think it's people in this room are the ones that are going to be kind of helping define this further. Thank you.
We have time for a question, maybe one quick question.
Curious about harnessing the registry, actually. There's a lot of talk about MR visible lesions that we heard over the last 2 days. I would even argue that is a characterization biomarker because we saw 4 genes that lead to visibility. So it's a biomarker, right? And it's predicting. It's not just localizing for recurrence. So there's probably a lot of information in the registry, and maybe we're not capturing when those patients have had genomic studies, but a lot of them may have had. Maybe we should think about that. We could actually learn a lot.
Great.
Yeah, I think it's a great point. I think that would be great.
Okay. Thank you. Okay, next up we have Dr. Katz coming to us from NYU Long Island to discuss the rationale for salvage focal therapy post-radiation.
Good morning. Thanks, Jim. It's a pleasure to be here. This is an area that I've been quite passionate about throughout my career. It's an area that clearly continues to evolve. I sit on the AUA panel for the consensus for salvage therapies. I have nothing to disclose, unfortunately. I just wanted to go over two concepts that you should be aware of in terms of the AUA guidelines that will come out rather recently. In the next few months, salvage ablation, applying cryoablation or HIFU are modalities that these traditionally have been applied as whole gland treatment, although these modalities may be used in selective partial gland or otherwise known as focal therapy. And as cryoablation or HIFU toxicity may correlate, not surprisingly, with the more that you treat, the extent of the ablation, it is suggested that the morbidity from local salvage therapy with focal therapy, cryo, or HIFU may be lower when compared to whole gland therapy. This has been my own experience, albeit without diminished oncological outcomes. And we are seeing many patients today that are undergoing different forms of radiotherapy. When I was initially training, it was brachytherapy alone for low-grade Gleason scores. Then it was combining brachytherapy with external beam, and now we're using SBRT quite a bit at our institution. There has been clearly an evolution, but we continue to see, and you will continue to see in your practice, many patients are going to come to you in your office or your clinic with radiation recurrent disease. And so our goals for these men are to eradicate local disease if that's possible, and then prevent metastasis if it hasn't occurred already, although I would caution you that we do need to be very careful with these patients as underlying metastasis may be already prevalent and present. We would hopefully like to delay the onset of androgen deprivation therapy, and I don't have to educate this audience about all of the potential complications and side effects of these modalities. Can we maintain the quality of life as best we can? And the main issues that have come about with any form of ablation in the post-radiated therapy space always comes about as preserving erectile function, if that's already existing. And there are a subset of men, I think, that still have reasonable erections despite radiotherapy, and they may have had combined radiotherapy with androgen deprivation therapy. We'd like to maintain their urinary control, urinary continence, and as well as their bowel function. And there was the dreaded F word, the fistula, in years past. And I think for the most part, this has gone away with our better imaging-guided techniques and our use and employment of argon-based technology, cryotherapy, and HIFU. And I have my most experience in my career has been with cryotherapy. And can we reduce anxiety? This is a question mark, but a lot of patients come to us, gosh, you know, doc, I thought I was cured with my radiation. Do I have to get my affairs in order now? How much time do I have left? These questions come about quite commonly with patients when you have relapsed cancer. So can we focally ablate and eradicate these cancers? And that's another area I think that we can help many men. I think that radiation recurrences, as I said, they do happen, not often, but they certainly occur, and they can occur rather early on in the first 18 months. That's typically rare because with radiation therapy, you continue to see PSA going down, although we do see a spike or what we call a PSA flare-up in the first 18 months. But they can occur anywhere from out to 10 years. I've seen patients come to my practice now with 15 years out with radiotherapy that are relapsing, and typically the only sign again, is a PSA rise, although a DRE, and I'm kind of old school, and I like to still have the guys turn on put their elbows on the table and pull their pants down and do a digital rectal examination. I think post-radiation therapy, this can be very important, but be wise about the PSA in the post-radiated setting. Be very wise, and even though small PSA rises, get an image test early. I have been relying, and I think it's quite accurate to get that PSMA-PET scan early when PSAs are rising, because patients are typically asymptomatic. Michael Zalewski, who spent most of his career at Memorial and is now actually coming to us at NYU, had a great paper. He's done a lot of work with radiotherapy, and he's recently published this paper on SBRT looking at the dominant intraprostatic lesion. If you listen to Dr. Samir Taneja's talk and many talks today in this session talk about this dominant intraprostatic lesion, the PIRADS 4 or 5. If you look at his studies, and he published this paper I'm sorry, showing that you can, in fact, predict which patients will recur. And the patients, he did 2-year biopsies after radiotherapy on everyone. And not surprisingly, the ones that have the dominant 4 or 5, if you biopsy that area and if there's recurrent disease, it's those patients that will continue to have a biochemical recurrence and progress. So what are our options for men? Currently, the potentially curative ones, radical surgery. Maybe there's a handful of people in this room that have done robotic surgery here, and I applaud them. I think that's probably a reasonable way to go rather than open surgery. These are very challenging, very difficult procedures to do. Cryo, HIFU, and brachy, and then the potentially controllable ones would be maybe a reflex. Most urologists, I think, in the country would still probably put patients on short-term androgen deprivation therapy, maybe for 6 months, maybe for a year, even without metastasis, and then maybe just observe patients. I typically, this was Michael's paper showing again that if you have a positive biopsy post-SBRT, at the 2-year mark, you will continue to progress. And this is a particular patient that had a 68 years old that had a seed implant several years ago. His PSA is now quite high, 6.7. We got a PSMA-PET. And it may be nice to localize it with a PSMA-PET. You can see that there's an area of unifocal cancer there. And I have not particularly, at this point, I still use MRI and I still always biopsy patients before I perform a salvage ablation. This is a 68-year-old gentleman with a rising PSA of 5.8. He completed external beam a number of years ago. You look at 10 years. PSA doubling time was 2 years. I think PSA doubling time can be very important as to the likelihood of patients with underlying metastatic disease. MRI showed a PIRADS 4 on the left. You can do we did an MRI fusion biopsy with systematic core biopsies, which we typically do. And, whether or not you do a transrectal ultrasound-guided biopsy or a transperineal biopsy, that's up to you and your practice. Many of these glands can be relatively small. I think for the less than 40-gram prostate, I don't think you need to bring a patient in for a transperineal. I think you can get excellent sampling with a transrectal ultrasound with these smaller glands. This particular patient had high-grade recurrent disease. Many of the pathologists will not give a Gleason score unless they feel that there is completely untreated radiation therapy in the area. Then they'll assign a Gleason score. But many of the patients that I get back just show high grade. You rarely see low grade recurrent disease. Cancers on one side of the prostate, biopsies on the right were negative. So this patient had a PSMA-PET that was normal. And otherwise, he's healthy. And I think this is something else that you want to consider when evaluating your patients as to the comorbidities of these men. Look at whether or not they have underlying cardiac disease, and are they really good candidates for ablation? This patient then underwent an ablation using cryotherapy, and I show you this you've seen these slides before in this meeting. He elected to use a 17-gauge ice rod system. For some patients that are considering or do have reasonable potency, and of course, all men lie about this, or they don't lie, but they exaggerate things. But this man was using Viagra. He had reasonable erection. So he said, okay, we'll do a nerve-sparing focal ablation using a color Doppler, which in my own experience has been quite helpful. And you can see this is the end of the first freeze. We always do a double freeze thaw, bringing it down. This is his 12-month MRI, showing that the area of the cancer has been eradicated. And you can see that his PSA went down really nicely, and I think this was brought out in a previous talk where even though you're ablating 50% of the gland, you can drive the PSA down to way under 50%, sometimes 75 or 80%. He has a nice shim score and a nice IPSS score, obviously an excellent result that I'm showing you. I usually use a Foley catheter for 3 days after the ablation. I use an antibiotic for about 5 days. All the patients get an alpha blocker for about a month. And then we do a PSA DRE every 3 months, and then for 2 years, and then every 6 months thereafter, they get IPSS scores and shim scores. And then we recommend just a biopsy based upon if the PSA is rising. And we do typically an MRI in a year just to ensure that the area has been eradicated. Somewhat of a busy slide. I try to put all the salvage focal cryotherapy outcomes here. Most of them are showing very reasonable outcomes. About 50% or more are free from failure. And this was a study that was just published by the UCL group. I wanted to show this. This was an external validation for a risk model. If you can predict failure from a salvage focal ablation, Very nice study. They entered a large number of patients into their model here, and what they showed, you can see these are the Kaplan-Meier curves on the right and the left of all the ablations, and then the other one was comparing cryotherapy to HIFU, and you can see projected out to 2 years, still about 50% of these patients have not failed by their definition of a PSA cutoff. What should a PSA cutoff be? It's typically, for me, would be a rising PSA over the nadir. And they went on to this model of can they predict patients who are going to fail from focal salvage therapy, looking at the baseline Gleason, PSA, MRI, and prostate volume. And if you want to look at this paper, it was just published in the British Journal of Urology about a couple of months ago, and you can come up with some modeling. I typically don't do this. I use my own gestalt and whether or not I feel that these patients are going to do well based upon their underlying characteristics. So none of the patients require hospital stay. I've never, thankfully, transfused a single patient. There's no really long-term complications, no risk of a secondary malignancy. Do I repeat the cryoablation in a salvage? Typically not. I try to stay away from that. I think in a handful of patients in my career I've repeated it, and I've not seen any real significant morbidity, but I definitely get concerned about these patients that have had prior radiotherapy. The incontinence rates are extremely low. If you do a focal salvage, less than 5%. It's not zero. Minimal anesthesia and a quick return to life. I think with the improvements that you've seen here in this meeting, it's a urologically friendly procedure, great outcomes, only one surgeon and relatively short learning curve. So just remember this, for these patients, it's a different subset of patients that have had radiotherapy. For me, if I can do a focal therapy, to me, less is more for these radiated patients. Be smart about early imaging and biopsy. Even though the PSA may be rising very slowly, they may have underlying metastatic disease, and the PSA may not be predictive as it is in the untreated population. Potency, if you can get potency, if you're lucky, great. You have to be very real with these patients. Let them know they're older now, they've been radiated, and now you're going to have a secondary procedure. So if you get it, great. If not, you're going to need intracavernosal injections, or you're going to need an implant. Less than 5% are wearing pads. We really haven't seen, thankfully, knock on wood, I'd say in the last 500 patients, no fistulas. Gland size is key. Size matters. And if it's really less than 20 grams, I probably would stay away from that because your incontinence rates are going to be higher. And if you can, try to spare patients hormonal therapy. Thank you for your attention.
A quick question. Many of these patients, the recurrence is in the SP. Are they candidates, the seminal vesicle? Are they candidates for focal cryo?
They are. In fact, I think Jim and Herb recently published a paper, I think in Journal of Endourology, if I'm not mistaken, looking at robotically removing the seminal vesicle, or as well ablating the seminal vesicle at the same time. It was a great paper. Of course, I'm biased because I work at NYU, and I have to say that. But no, it was a very interesting paper. But yes, you can, and have great results. You have any comments?
Yeah, no,
on that, Jim?
I think one of the issues with trying to ablate disease that's extending into the SV would be the margin control in that region. And so what we've adapted is a combined robotic SV excision to the margin on the ablation at the same time in the same procedure. So basically you leave your thermocouple at the SV base junction. You know you've got a kill temperature there, say negative 40 degrees. You leave that in place and then you cut down to that needle. Yeah. And then you've ensured that you've got as good of a salvage margin as you can. And the morbidity of the robotic SV excision in the salvage setting is very low. We don't have any real morbidity from that portion of the procedure. And it does beg an interesting question is when you do have the local recurrence after radiation, is how do you properly stage that patient? Do they need routine SV monitoring as well?
Yeah.
Biopsy. So
yeah, I had been doing that in the past, but now with the MRI, if the MRI is negative, I've gone away with that. But yeah, your results look great, and the PSA outcomes in these patients look very good. So it's a great job.
Michael.
Thanks a lot, Jim. Dr. Katz, great talk as always. So I think it's important to re-stress the point that you had said about using PSMA imaging in these patients. The
Yes.
PIRAD system was designed obviously in the treatment naive patients, and now we have what is it called, the PI-RR for radiation recurrence, and the negative predictive value of that system is somewhere in the range of like 35 to 50% at best. And if you have a patient who had brachytherapy and they had seeds inserted, all hope is lost of imaging anything.
Yes.
So in my practice, I've just done away with doing multiparametric MRI entirely in the patients after radiation and moved to using PSMA-PET, where we know that the positive predictive value is like 98%, and the negative predictive value is closer to probably 70 or 80%. The challenge, though, which hopefully our industry partners here could help us with, is being able to actually perform a biopsy once you have a PET CT scan. I'm curious, in your practice, how do you use the PSMA-PET to actually perform the biopsy when many of our biopsy platforms are limited in its capabilities to do that?
Yeah, and first of all, I think that's really smart, the way that you're doing that. I typically have not gone to just using the PET. I use the PET to make, before I do a biopsy, to see that I have metastatic disease. If the PET is negative, I get the MRI, and then I use the MRI for biopsy. I haven't just used the PET as a platform for biopsy. But I think you're spot on with that, and maybe we're moving in that direction.
Just a plug for my friends at Koelis. Everyone knows I'm a big Koelis user. They actually allow you to take the PET CT and fuse it to ultrasound to do a PET guided biopsy. But most people don't have that system, so we need help from the other players to be able to do this.
Great. Thanks for bringing that up. Thank you very much.
Yep, thank you.
It's my privilege to present Dr. Moore to talk about extended indication for focal therapy.
Thank you for the invitation. So the rationale for treating Gleason grade groups 3 and 4, the title presumes that there is one, but we'll have a look. So what I might say is, what's the rationale for treating higher risk tumours? Because as many of us have said this morning, we shouldn't just be looking at the biopsy. So how do we currently determine risk? Well, the NICE and the NCCN guidelines talk only about Gleason grade, PSA, DRE. They don't mention MRI. But when we look at these two patients, who were two real consecutive patients in my clinic about a few years ago now, both with 3 millimeters of Gleason grade group 1, the man with the large left peripheral zone lesion told me that he didn't want treatment, and the government said he didn't have to have it because he has Gleason grade group 1. I said, well, the government hasn't seen your MRI, so let's talk about it. We've seen this paper a lot. The MRI counts, both visibility and volume. So how should we determine risk? Well, Arnauld very kindly already showed this, which was a group of international experts looking at surveillance, really looking to see, how do we actually determine risk? Do we slavishly follow the guidelines, ignore the MRI, and follow the NCC risk stratification? Of course we don't, but perhaps we should recognize that. So Gleason grade, MRI, and then the other things come after that. Having said that, I will present the data that we've got stratified by Gleason grade. So this was quite a while ago now, 2016, 625 men, multi-center HIFU. And if you look here at the factors that differentiate failure, I'm not sure I'll be able to get the pointer to work, but if you look at Gleason grade, that one with the massive steps below, that's Gleason 4+4 or grade group 4. So a massive difference. So you really, really want to consider carefully whether that's something that you want to do. Gleason 3+4, standard indication. 4+3, higher rate of failure, but can consider, and then the others. We looked at it in our essentially single center, single group outcomes of over 1,000 men. And again, we see a big drop-off between the 4+3s and above. So it doesn't mean that you can't do it, but you need to be careful. Now, of course, the whole point in this sort of approach is that you can personalize things. So quite an unusual case, a 65-year-old man with bilateral cochlear implants I don't know if anybody has tried to get an MRI in this situation, but you can do. So the neurosurgeons offered to remove them, make him deaf for his time of diagnosis, treatment, and recheck. And I said, I think that's a bit much. He had a PSMA-PET focus. It was positive, 3 millimeters of 4+4. We did get an MRI, and what you can do is to get the manufacturers, they will make a splint to go on the head. You take off the external bit to try and keep the thing in place. And as long as it doesn't warm up or give them a headache, you can do another one. So it's a little bit hairy, but you can do it. Unfortunately, he was MR negative after that whole palaver. After much discussion, we went ahead, did HIFU. We did his post-HIFU MRI to check the ablation zone in relation to the area we treated, even though it wasn't visible. And he's been negative for recurrence, and we've done MR, PET, and biopsy because we knew this was difficult to find one and high grade. So I would say that you can consider treatment in Gleason grade groups 3 and 4 if the MRI volume is small, if the patient is motivated, accepts close monitoring, and understands that they may need to go on to focal radical treatment. Radical treatment. And we should be, as we all know and have talked about, moving away from treating any low-risk patients with no visible disease. Happy to have any questions.
Thank you, Professor Moore. That was great. One quick question. We've heard this theme sort of emerging over the morning is volume of disease. You just concluded that you would treat 3+4 if it's a low volume, or 4+3 if it's low volume. What would be your criteria for low volume, and how would you assess that? Is it an MRI, or is it a biopsy volume, et cetera?
So what I want to know is to know the sort of maximum burden of disease. So we can get the best estimation of tumour volume from the MRI, usually the TT-weighted sequences, and the best confirmation of that from the targeted biopsy, looking at the maximum cancer core length and then the percentage pattern 4. So I would put all of those together along with all the other things we assess. Do
you have a cutoff?
I wouldn't treat more than 1 mil of 4+3 probably, but 1 mil is pretty big. So no specific numbers. It's about what the aim is for the patient. I've done it. We have some patients who've completely refused other things, and I think, well, at least this will delay hormones. So we do it on that basis for some sort of severely psychologically affected people. But yeah, so no numbers, cut off decisions.
Great, thank you.
Patient discussion. John.
How about the elderly patient with high-risk disease? It typically gets put in watchful waiting. Do you think there's a role for focal rather than wait till they get painful metastasis or, grow into their bladder floor or that sort of thing?
I don't tend to. I think there's definitely a role for treating high-risk disease to avoid radiotherapy in the elderly patient. So I don't very often do bilateral focal therapy, but I have done in somebody with small bilateral Gleason 4+3s who didn't want 6.5 weeks of daily visits for radiotherapy, and he's 5 years out and have done very well. But I think if they're in the bit where we're not saying they're suitable for anything, tend to just wait and hormones if needed.
Caroline, thank you for your great talk. What do you make of cribriform pattern 4? Is it for you a red line? Because our pathologists always stress that this is equivalent to high risk. Yeah. So what do you make of it?
So I don't think it is an absolute red line. Again, unusual case, but I've got a chat with cribriform on active surveillance. He's been on surveillance now for 9 years. He's got a tiny, I know him very well, left apex, 2 millimeters, same on repeat biopsy 3 times. So very unusual, but it's small volume disease. He was initially told you must have a radical. He came to me for focal. I said, I'm not sure you've got enough. And actually, he's now got leukemia. He's probably getting on to the watchful waiting end of things. So I think it's not that I would ignore it. It's definitely a risk factor, but it's not the only thing.
Thank you.
One last question, Dr. Khalil.
Great talk. Question, we heard earlier about genomic markers. How do you incorporate them in these kind of patients?
Not at all. We just don't use them. We're investigating them for, in the Reimagine Risk study, 1,000 men, but I never request them.
Thank you.
I would like to invite Dr. McClure, interventional radiologist and urology at Weill Cornell, to talk about in the setting of oligometastatic cancer.
So take a little mental break away from prostate cancer for a short period of time. No relevant disclosures, and we're really here, or I'm here really here just to kind of show an overview of what we can do in IR to help manage oligometastatic disease with GU cancer. We know that ablation is an established treatment option for small renal masses, and its role is evolving. It's now included in the NCCN guidelines for T1B tumors, and its use in oligometastatic disease is increasing as well. The standard techniques are similar that we see cryo, microwave, radiofrequency ablation, IRE, as well as ethanol, and there's probably an evolving role for PEF as well. An ablation of oligometastatic disease requires careful patient selection as well as a clear understanding of the ablation techniques to help minimize complications. And I just want to show a quick overview of kind of what we can do so you can understand what's possible. So this is a patient with an oligometastatic RCC, 76 years old, in 2011 underwent partial nephrectomy for a T1B. There was tumor disruption at the time of surgery. He had done well until 2018 when you see in the left side, right along the diaphragm there, there's an enhancing nodule. This was biopsied, which confirmed RCC. He then went percutaneous cryoablation. You can see that I was unable to get that nodule off the diaphragm. So in that situation, we would do cryoablation as opposed to microwave to minimize the side effects from that. And you can see in follow-up, it resolved. The management of these retroperitoneal masses is important because, as you can see, sometimes they're up adjacent to the colon. So this is a patient who had two nodules in the retroperitoneum. And when we approach this, you place the ablation needle into the probe, and then you do hydrodissection to move the colon away. So this is in yellow showing where the colon is, hydrodissection with D5 water. You can get that colon away from the tumor to sufficiently ablate this. This is important to realize. Sometimes when there's intraperitoneal mets, it's impossible to get the colon off of the bowel because you're just going to create ascites. So this is a trick that only occurs when the lesion is within the retroperitoneum. Another case of using lung nodule management. This was a solitary nodule that developed on a patient while he was on systemic therapy. Rather than changing the systemic therapy that the patient had for his RCC, we did a percutaneous microwave ablation with good results and no recurrence afterwards. So there's not a lot of literature on the management of oligometastatic disease with GU malignancy. This is from Thomas Atwell's group at Mayo that looked at 80 patients. And you can see that 1 year there's about local recurrence rate of 94%, and at 3 years, 84%. A little lower than what you'd expect with percutaneous ablation for small renal masses, but still reasonable. Another situation you have to be careful about is adrenal. This is a patient who presented poor surgical candidate, 2-centimeter adrenal mass. He underwent percutaneous microwave ablation. The thing we have to be aware here is that it can be done outpatient, but it does require general anesthesia. You need A-line monitoring for intraprocedural monitoring for hypertensive crises. I use a preoperative alpha and beta blockade, which is basically doxazosin 1 milligram for 2 weeks, and then a beta blocker 4 days before the procedure. And then in patients who've had prior adrenalectomy, it's important to get endocrinology involved to make sure there's no adrenal insufficiency afterwards. This was a meta-analysis of numerous papers looking at management of ablation within adrenal mets. And you can see that the local recurrence rates are fairly good, about 80%, with a confidence interval between 76 and 83%. The PSMA era is providing us with unique presentations for prostate cancer. This, particularly in the setting of an oligometastatic disease where you either have a solid nodule, or in this situation, a patient who had undergone prior radical prostatectomy for a GG2. He had a positive margin on the left side that after treatment, his PSA rose. He underwent radiation therapy and hormone therapy. His PSA went down, but about 2 years after that, he recurred. So the question is, how do you manage the solitary MET? He was vehemently against restarting hormone therapy because of the side effects that happened with this. So what we did was, under ultrasound, make sure that we could identify where that lesion is. And these are tricky cases because it's very difficult to see on ultrasound. You can see the how kind of it's just an anechoic kind of blob of tissue that's very difficult to see. So I've always biopsies in a staged procedure to confirm that there is in fact cancer there. We then targeted that with IRE to treat that, and then as you can see, the result, the PSMA went away, or the PSMA avidity went away, and the imaging characteristics correlated with the PSA kinetics, as you can see, as PSA dropped as well. So there's probably a role for ablation with these oligometastatic diseases outside of radiation. How we do that remains to be determined. Thank you.
Okay, thanks, Tim. That was great. I think that's an interesting display of those PSMA findings, because we do get those referrals, and it is a tough spot because they've had radiation, they've had surgery, and how to get there. But I think you say you always biopsy it first, correct?
You always have to biopsy. And the other question is, can you resect it? Anecdotally, I've seen hit or miss results. And if you look at the data, management for like oligometastatic disease with lymph nodes, I mean, the outcomes are like 50%. So we have to find a better way of managing that.
Yeah. Okay, thank you. Okay, so I'd like to invite up Dr. Martinez-Salamanca next for our next talk, Value of PSMA-PET in addition to MRI and biopsy for patient selection for focal therapy.
Hi, good morning. Thank you, the Focal Therapy Society, for giving me the opportunity to be here. I'm going to try to share with you some ideas of how can be useful the PET scan in addition to MRI. I think probably the CT imaging is we know that it's poor for soft tissue contrast, and especially for prostate imaging. Probably this is the rationale to add or to try to combine these two techniques. I think this meta-analysis published in 2019 show the idea of diagnosis and primary and biochemical recurrent prostate cancer. And I think that till now we have very good definitions that this could be helpful in the diagnosis of the primary and also to evaluate patients with BCR. This is a systematic review published in 2020 showed that the combination of PET MRI proved a high sensitivity in detecting primary cancer and also the detection for recurrent disease, especially using the PSMA as a radio tracer. We published this systematic review in European Urology Focus in 2020, and trying to review the current data at that time. I think the first idea is that the evidence is overall very low. 70% of the studies are retrospective, only 30% are prospective, and there was not enough data to run a meta-analysis. This is the reason why we did the systematic review. I think that these two concepts are, clearly defined today. If we are talking about these two techniques, is extreme variability to use a PSMA PET in combination with a multi-parametric MRI, and also there is extreme variability on the data and also on the indications. I think this variability can come from these probably four sources or reasons: the PSMA tracer use, the image acquisition, the image interpretation, and also the histological comparators that we have used until now. I think that you are aware that there are many tracers, probably are only two approved in the US so far. There are other many trying to approve or get indications all over the world. Basically, the gallium and the fluor is the one that but you can see here in this table that there are many under investigation and under trying to get the approval. Also, on the images acquisition, there is no so frequent to have the two machines to do the integrated systems at the one time. These are the four, more common ones from General Electric, from Siemens, and from Philips, but it's not so easy to get this and to have this machine to do the both studies at the same time. So probably, I think the majority of you, probably in my country, is this way. We try to get these images acquisitions in 2 times. The first, patient get the MRI, the multi-parametric MRI, then the PET with usually 2 different readers. So this also adds some confusion or some bias to the final results. And then using several fusion programs, some of the attendees already mentioned about that. And then you can get these 2 images combined. You have probably with the multi-parametric MRI, the PRS, it's a very good classification, but for the interpretation of the PET, there is no any standard interpretation, so you need to use the Likert scale, and this is something that also can add some variability, and whether it's nuclear medicine with a radiology, or if a person that they manage the 2 techniques, so this is something that needs to be clarified. Also, the histological comparators, we have prostate biopsy or prostate specimens after radical prostatectomy. So these also need to be clearly defined when you're evaluating the results of these 2 techniques. I think that there was 2 options to try to see if the 2 studies are coincidence in the same area. To use this row stringent, the 1-to-1 approach. This means that they need to be exactly in the same site, or use the alternative neighboring, which allows you to try to make a coincidence closely, but not exactly in the same area. Could be in the same sector. So this is something also need to be better defined. This is results from the systematic review we published. If you see, I think the beauties of the combination could be the soft tissue contrast, which is much better than the other ones, but also the duration of the procedure and the cost could be also more. I think these are the things that potentially this combination could help on the prostate cancer detection, on the intraprostatic localization, on the staging, response to treatment, re-staging. I think we will see many of these things addressed in the next years, probably in more detailed studies. This was a landmark paper published in 2016, trying to show how this technique could be nice to have a better localization of the tumor and also best cancer detection rate. You can see here that the cancer detection is better. You can go up to 98%. And also the location, which is more important, also could be much better if you combine the techniques, trying to go up to 98%, 67% sensitivity. Also, these papers show that it's very good on the tumor location, and also is likely to be effective as a diagnosis of a primary cancer. About location, this is probably one of the most important things in order to selection for focal therapy. I think the combination show that it's also very good. You can see here this very recent paper published. If you go and see the green line, you can see that when you combine the 2 techniques, tumor location is going to be much better. Also another study trying to show how this combination could be useful on the follow-up of, for example, in this case, if you use a HIFU, could be even better than the MRI to detect recurrence on the site. These are 2 clinical trials that are ongoing, both in Europe, one in Italy and one in France. This is also from the US, that they are trying to explore that this combination can have a future and role on patient selection for focal therapy. So I think that the take-home message is, I think this combination have a great theoretical potential in focal therapy, both in the diagnosis, in patient selection, follow-up, also treatment planning strategies. I think the prostate cancer detection, when you combine both, is optimal, and even the location is much better when you are doing the 2 techniques combined. So we need more data to make more clear recommendations. Thank you very much. Questions?
So, yeah, real quick, just you say that this could be potentially better at localizing, but where would we work it into the workflow? Because presumably you wouldn't get the PET until you have a diagnosis. Would you include this in a more of a screening paradigm?
Well, I think this is still even more a difficult question to answer based on the data. I think in the more practical point of view, we are using in whatever case that you try to want better results. For example, I think it's very useful if you are doing a focal therapy after, for example, a failure of a previous focal therapy, of a previous radiotherapy. This could be a very nice scenario, or cases that you don't have very clear things, or the ones that you be pretty sure that you are treating the area. But I think it have a great potential.
So Jim, to answer your question, in Australia, they published the results of the primary 1 trial, and that trial was designed specifically to look at PSMA-PET as a reflexive test after multiparametric MRI to rule out the need for performing a prostate biopsy. And they found a negative predictive value of like 99% or something like that. If you have a negative multiparametric MRI and PSMA-PET, you could walk away and not perform a biopsy. And now they've launched the primary 2 trial, which is looking specifically at patients with equivocal findings, PIRADS 3 lesions, to look to see, can you do a better job triaging those patients? And so in their view, it's meant to be used in the workflow of after a multiparametric MRI for secondary screening.
Yeah, that's very interesting. Thank you.
Thank you.
Okay, so and for our last talk, Dr. Tay joins us again from Singapore. Saturation biopsy in selecting patients for focal therapy. Outcomes from a phase 2 clinical trial in focal therapy.
Thanks so much, Jim. And thanks everyone for your time. And thank you for the organizing committee for having me here. So, I'm very interested in better patient selection for focal therapy. But at the same time, my center is very cost conscious. So biomarkers and doing PSMA-PETs before focal therapy or even before biopsy, because that's what we'll probably have to do, is going to be difficult. So I rely on the crude tool, which is to do many biopsies. And I'm here to kind of share a bit of my experience on how we've done that and what we get. So this is an example of a patient who came and when we started our trial, he wanted to have an opinion for focal therapy. So he had a biopsy in that target area outside, and he asks, can I just go for focal, or should I do a repeat biopsy? Do I need a systematic biopsy? And to include him in our trial, we did a systematic biopsy for him. But I think the real question, and to perpetuate this, is systematic biopsy really necessary? So I think there are a few sub-questions that come in, and many of these have been spoken to by the earlier speakers. What is the incidence of CSPCA when MRI is negative? And how many of these CSPCA, so-called, are actually significant, since they're typically not the index lesion, and these are what we've been shown are the invisible lesions? And finally, how would treating these cancers affect focal therapy treatment templates? Would it actually disqualify some patients from focal therapy? And finally, I'm going to show you some real-life examples. So we know from PROMISE, which was an excellently conducted study, that a negative predictive value for mpMRI is really in the region of 76 to 90%. And that depends on what is your definition for CSPCA. If you find that you can tolerate up to Gleason 4+3, that means you accept 3+4 as not clinically significant, then the NPV can be as high as 90%. But if you can't tolerate any pattern 4 at all, that means even 3+4 would be clinically significant, then that would be, the negative predictive value would only be about 75%. So you would miss 25% of clinically significant prostate cancers. And these are just a selection of studies which looked at targeted and systematic biopsies. And the miss rate, that means a cancer that's detected on systematic biopsy only, is about 15 to 25%. And these don't even include all the studies that many of the speakers have presented today. So there's also this very interesting study that's been presented many times, Wayne Brisbane and from Dr. Lenny Mark's group, which I think is very impressive, looking at how many % of the clinically significant prostate cancer are really within what they call the penumbra of the ROI. And this has found that 90% of the cancers are within 10 millimeters of the ROI, but there is still a 10% miss rate for clinically significant prostate cancer. And the question really is, can we tolerate that? So, and again, it's been shown in many studies that the outfield recurrence rate for both outfield any cancer or outfield clinically significant cancer, which is that smaller box plot, is really around the 10% rate. So this correlates with missing outfield disease, and whether we can tolerate that, perhaps we can come back and retreat that. So in preparing for our clinical trial, we really went to town with biopsy. So we didn't just target the lesion, we also did a saturation biopsy. And on average, we performed more than 20 calls of saturation biopsy. And we did pick up a significant number that were detected only on saturation biopsy. There's a bar in red, that's about 7 to 10%, depending on the Peyret's grade. And this was also, we looked at what are the factors that predict positive cause outside the target area, and this include the Peyret's. We found that if at a higher Peyret's score, actually we detected less positive cause outside the target area, especially when there was Peyret's 3, lower Peyret's score. We actually had more positive cause outside the target area. Whether that indicates that the cancer is more diffuse, generally a significant index lesion, that could contribute to having more clinically significant prostate cancer. We also found that when we had a discrepancy in the MRI truss model volume, that could mean that the radiologist has not included the entire MRI in segmentation, or there was some segmentation error when we did the ultrasound, and therefore, the fusion would be less accurate. So we then looked at 400 men who had undergone this kind of biopsy in our center. And then we looked at what happens if we do a simulated reduction model, remove some cause, and see whether that reduces the detection rate. So you can see when we did an all-core biopsy, the mean number of cores performed is about 22 cores in this series. Then we went on a reduction strategy. We did only 2/3 of these cores, half the number of systematic cores, 1/3 or 1/4. And we did find a reduction in detection rate. So it went down from 21% detection rate detected by systematic biopsy only of any Gleason 3+4 cancer, all the way down to about 8% if we did only 6 cores systematic biopsy. We also found that if we did a simulated planning of a focal therapy ablation template, we found that by reducing the number of systematic cores done, there were less focal therapy ablation zones. So if you look at the column on the right, and deemed no longer suitable for focal therapy, we actually found that when we did all cores, 10% of patients were excluded from focal therapy, compared to 4% if we had done only 5 to 6 cores. So this is an example of a case where we did a systematic biopsy in addition to the targeted biopsy. You can see that the image on the upper row shows those that were the targeted biopsies only. And in fact, we only found 3+3 cancer in the target area. But then when we did a systematic biopsy, we actually extended the size of the lesion to be treated. We found clinically significant prostate cancer that was in the anterior horn that was adjacent to the ROI. So we included this in the treatment zone as well. This is a picture of a treatment where we show the ice ball including both areas. And I showed this yesterday, so we treated 42 lesions in our clinical trial. 70% of them were MRI visible, 30% of them were MRI invisible, and those were picked up by our saturation biopsies. And really, the role of the saturation biopsy in this setting, most of the time it helped us increase the size of the index lesion for treatment. So again, this comes back to the issue of margins, and it helped us define the treatment margin better. And I think that also speaks to the result shown in Dr. Lenny Mark's group, which is that the lesion is often larger than what we think it is. But we also had a 25% pickup rate of MRI invisible prostate cancers. And 7 out of 13 MRI invisible lesions were more than 3+4. So finally, coming back to the case study, this is the case that I showed you at the start. We did a targeted biopsy of the ROI, and this showed 3+4 in that area. We also detected 3+4 outfield contralateral, so there was only 1 core. But he eventually underwent focal therapy, and we treated both areas. As you can see, the PSA came down nicely. And at a 1-year repeat biopsy, we did a repeat targeted biopsy of the treated areas. A new lesion was seen in the left anterior zone that turned out to be prostatitis. and we went to town again with the biopsy, and we didn't find any cancer. So to summarize, I think systematic biopsies, they still help us detect clinically significant prostate cancer at about 5 to 18%, especially in scenarios with less certainty, like when you have a low Parrot score, it's not certain where the index lesion may be, or if there's potential fusion or segmentation error. I think that doing less systematic cause means finding less clinically significant prostate cancer. What does that mean? I think that's open to interpretation. If your outcome measure is a negative repeat biopsy later on, then it makes sense to do more biopsies at the step of selection. And finally, the long-term impact of treating or not treating MRI in visible lesions, to me, I think it remains unknown. So I continue to do these biopsies so that I can make sure that the patients do not have CSPCA at follow-up. Finally, to do a successful focal therapy, I think everyone has shown, requires a very strong imaging biopsy team. And the extent of biopsy, I guess, it can be adjusted based on institutional experience and outcomes. I think if there's a strong trust in the reading radiologist, then perhaps doing less systematic biopsies is acceptable. Thank you very much.
A quick question. Do you find any relation about the recovery of the sexual function after the focal therapy in terms of how extensive was the saturation biopsies?
Not the recovery of the after focal therapy. I think that depends on how much you ablate. So I think I showed yesterday that if you ablated, including one neurovascular bundle, then you had a delayed recovery of sexual function. But I did anecdotally encounter patients, and we didn't do their EPIC scores after biopsy. This was not a trial of the biopsy, but a trial of therapy. And there were patients that, after undergoing a very thorough systematic biopsy, they did report that there was some impairment to their erections, but most of them did recover.